Let's be honest, heterotaxy is tough. It's a challenging topic. Probably one of the most complex aspects of imaging and getting it fully straight. But with practice and with sort of a set of structure as to how you approach your imaging, you can get most of the elements correct. I'll just recount that, in my own experiences, the actual diagnosis of, complete diagnosis of heterotaxy syndrome continues in any one individual, continues to be an ongoing process. In other words, even with the development of confidence prenatally that we have most of the elements, that can change at birth, and postnatally, classic for pediatric cardiologists to be debating whether a vein goes into where you think it's going in, or whether an SVC is where it is, and sometimes determining whether it is asplenia or polysplenia. There's sort of an asymptote of knowledge that we can get to, but we continue to generate that information even after birth. But nevertheless, being suspicious of heterotaxy syndrome and nailing some of the elements that are key for prognosis and counseling is something that should be able to be done prenatally. For some folks, mentioning the word heterotaxy creates this image of all sorts of emotions. I was given the title of this talk, the ins and outs, and so I thought of Inside Out, which is a great set of films. It's now an Inside Out 2, if you haven't seen it. So, that's the full range of expressions and feelings people have whenever you do mention the word heterotaxy. I'm going to take a little bit of a philosophical approach to this at the start here and talk to you about the notion of symmetry and symmetry in nature, because that's where heterotaxy derives from. The fact that we have a perception that there is beauty and symmetry in all things in nature. And in fact, Leonardo da Vinci had that same concept when he drew the Vitruvian Man. Vitruvius was a Roman, either Greek or Roman, I think it was Roman, architect. Yeah, it was Rome. And believed in the notion of symmetry as part of architecture. And Da Vinci looked at that concept and, in fact, believed that the construction of the human body could be fully defined mathematically by circles and squares, and therefore he drew this Vitruvian Man, this, quote, engineered man, as part of this particular, famous diagram drawn at the late 1400s. But lo and behold, scratch just a little bit beneath the surface of the human body, and it's not symmetrical. There is clearly defined asymmetries that are part of normal. And so asymmetry is natural, is part of the inherent biology of the human body. Although on the surface, again, nose central, eyes on each side, we have two hemispheres of the brain, two supposed equivalent limbs. And interesting as well, if you think about this, the presence of this symmetry externally is pleasing to us. It defines beauty, because think of the contrast. Many of you have seen unfortunate situations of a cyclops or fetal anomalies where you, on the exterior, truly lose that symmetry, and it's disturbing to us from our own nature. But yet internally there is asymmetry. We are asymmetrical. Our hearts normally should sit on the left side. Our stomachs are on the left. Our livers are on the right. And then once you get to the intestines, there's a particular set of rotation of the intestines, which may seem random, but is far from random. It's very well defined with a number of ligaments that adhere the intestine, in particular sites and spots that allow for normal peristalsis and movement of food through the intestines and such. Again, very well-defined asymmetry. So how do we achieve that asymmetry, that normal asymmetry? It is inherent and part of early signaling of cells, very early in development. Now, one of the best explanations of this, I have to tell you, I found in the New York Times. And this is back in 2013. Carl Zimmer is a popular science writer. He's written a couple of different fantastic books. And he continues to write for the New York Times Magazine as well. And he did this piece on growing left, growing right, which you can look up. It's still available. It's about a 2-page article. If you want to understand situs inversus or heterotaxy for a lay population, this is the article to go to. And as a subset of this, he had a small little breakout piece where he was reporting on the biological basis of sidedness. So how does this normal asymmetry internally actually develop? It's fascinating. We now know that as we start out as a group of cells, very early in human development, there are tiny little cilia, little hairs, that sit on the surface of the zygote. And those cells that have the cilia attached to them dictate cilial beating in a particular direction. And that direction moves all sorts of, at the moment, unknown molecules and elements, and proteins, that migrate to certain parts of the zygote and then define the asymmetry, the differentiation that we see internally. So critically essential to all of this is the proper movement of these tiny little cilia. So here in this example in the third panel, it's the leftward flow of fluid, movement of cilia that then moves these proteins, this molecular environment to a particular part of the zygote, and then leads the cells within the zygote to differentiate into the normal asymmetry. So what's happening in heterotaxy syndrome? Something's going wrong early at this point with where these little hairs are beating. Either they're beating in a non-coordinated manner, and therefore these molecules that tell the organs where to form don't form normally, or, interestingly, in situs inversus totalis, where everything is exactly mirror image, somehow these cilia are beating in the total opposite direction, but in a synchronous way. So I find this fascinating because what we've now even more so discovered today, and Lynn mentioned this just a bit in her discussion with Cartegener syndrome, there is a very high association between heterotaxy syndrome and ciliary dyskinesia, which is the consequence of these tiny little hairs that grow into all of our other little hairs that sit in our airway and in our sinuses and in other systems of our body that then can be dysfunctional, again, derived from this very, very primitive early situation in which these cilia are not beating in a normal direction. So there's a lot of work continuing in this domain, what causes these cilia to beat in this different direction and such. But in essence, this is the current understanding of the origins of heterotaxy syndrome today. It's abnormal movement of these very, very primitive early cilia. So translate that into where we are clinically. What is the heterotaxia or heterotaxia syndrome? Well, it has an incidence of 1 per 10,000 total births. The male to female ratio is about 2 to 1, interestingly. But when you look at the females, they're a bit more likely to have a particular type of heterotaxia referred to as polysplenia. So I haven't explained what that is just yet, but we generally believe that there are 2 types of asymmetry. And the way I think of this is you got too much of a right-sided dose or too much of a left-sided dose of your body. Right? We know there are certain organs that, as part of our normal asymmetry, sit on the left side, heart, stomach, on the right side, liver, and we're going to talk about some other features in more detail as well. So if you have abnormal asymmetry, You may have too much right-sidedness on both right and left side, or too much left-sidedness on both right and left sides. And that's what defines the asplenia-polysplenia difference. In asplenia, there's more right-sidedness. Another term for that is right atrial isomerism, it's a term you may hear, where in fact we have a right side on both right and left, or polysplenia, in which there's left-sided isomerism. You've got left-sided stuff on both your right and your left. It's a way for us to categorize the variabilities in heterotaxy so that we can best understand it. A couple of other facts here. In fetal life, there's a predominance of polysplenia that has a higher fetal death rate, and maternal diabetes has recently been identified as being a bit of a risk factor for heterotaxy as well. Perhaps the maternal diabetes being something that alters that early environment of ciliary movement, and that dictates the position of the organs. There, of late, has also been a development of some genetic associations, almost always a normal karyotype. There is about a 5 to 10% recurrence rate in siblings. Gosh, reminds me, I have a family, one particular family, they had 4 pregnancies, this mom, and all 4 had evidence of asplenia, 2 of which she carried forward, and the last 2 of which she did not continue the pregnancy, but just fascinating situation. So definitely, practically speaking, this can recur. There have been a particular number of genes that have been identified, and in fact, although we mentioned earlier we don't like to do panels, I just show this as an example of the fact that there is a number of heterotaxy panels that are out there that can be, of course, helpful from the perspective of identifying the risk for recurrence in families, and drilling down a bit more into detail as to what the genotype-phenotype connections might be that may help from a prognostic perspective. So the spectrum of this asymmetry ranges from, against what we refer to as situs solitus, where the organs are asymmetrically normal, heart on the left, liver on the right, stomach on the left, spleen, single spleen on the left, to right atrial isomerism, or asplenia, left atrial isomerism, or polysplenia, and then the element of situs inversus, where everything is totally reversed. What are the particular features that help us identify what is normal asymmetry versus abnormal asymmetry? So let's drill down into this a little bit more. And again, all of these tables should be in your handout, and therefore something that you can study and analyze at a later point in time. There are a couple of tables here, I think, that you just sort of should keep as reference as you gain further experience in imaging heterotaxy syndrome and such. It's just not something you're going to be able to totally commit to memory. I haven't, but I use these as references whenever I want to sort of make a decision whether I think somebody has asplenia or polysplenia or such. But just some interesting examples of what normally sits on the right side. You're not to go through each one of these, but the lungs, you have a right and left lung, you think that they're symmetrical, but they're actually not. There are 3 lobes on the right and only 2 lobes on the left. Some people may have an additional lobe on the left. The way I think about this is because the heart sits on the left, and so the left lung is a little bit smaller than the right lung, so the left lung's got 2 lobes, the right lung has 3 lobes. Very, very unique to the heart, and very characteristic of something that's right-sided versus left-sided, are your atrial appendages. And so we mentioned it early yesterday that we can image the atrial appendages. Theoretically, yes, but I will tell you it's challenging to identify the atrial appendages unless you've got a perfect picture. And even when you see them, what you need to be able to distinguish is that a right atrial appendage is much broader based and has a triangular appearance to it, while the left atrial appendage is more finger-like and slender and narrow. And because the atrial appendages are remnants of early development of the heart tube, they hark to the sidedness very closely. The problem, again, is that it's hard to image, and often when you have additional cardiac anomalies that alter the loading conditions and filling of the heart and the atria, you might have a left atrial appendage that's under a high volume state and it dilates. And therefore, is that a left atrial appendage or is it a right atrial appendage? It becomes hard to tell. But nevertheless, these particular features do help define the difference between right and left. One particular means of distinguishing right from left that I have always found interesting, and because as cardiologists we look at lots of angiograms and x-rays, this we have found to be helpful in identifying a right side versus left side. In a normal situs, one has something called a hyparterial bronchus on the left and an eparterial bronchus on the right. What does that mean? It defines the relationship between the bronchus and the pulmonary artery. So on the left here, one should have a hyparterial bronchus, meaning the bronchus travels below the left pulmonary artery, as you see here. Okay? And in heterotaxy, you may have a hyparterial bronchus on the right side. Here's the right, and here is the bronchus running under the pulmonary artery. So this particular configuration indicates a left-sided phenomenon, something that should normally be on the left side, but it's on the right. So we got too much left-sidedness. This is a case of polysplenia or left atrial isomerism. All right, so in relation to tables of reference, I'm about to show you the table that every talk on heterotaxy has to have, and that is this table here. All right, the clinical anatomical manifestations of asplenia versus polysplenia. Again, it's in your syllabus, so you should have this as a reference. And what's interesting is that there's a blending. Not every single particular finding is definitively left-sided or right-sided, but there are percentages. So, for example, bilateral superior vena cava seems to be a common phenomenon of both the asplenia and the polysplenia syndromes. It's seen in a little bit less than half, where you may have both a left SVC and a right SVC. Now, let's look at some of the things that are a little bit more percentage-wise seen in one or the other. Interruption of the inferior vena cava. I'm going to show you some examples of that. Predominantly a feature of polysplenia. If that is seen, you're pretty confident you're dealing with polysplenia. Now, let me just, as an aside, because I don't think I've mentioned it, but when we talk about polysplenia, it means that there might be lots of small spleens that you may not be able to image. The functionality of these spleens is still often of question. So in other words, even though they might be present, often they don't function very well, and so somebody with polysplenia may still have functional asplenia, and as a child, young adult, may need to be protected with prophylaxis of antibiotics. But there are certain additional things that go along with each of these. So again, polysplenia more so, interruption of the IVC, rare, but have seen it in asplenia. Let's look at other things that are dominant in one or the other. Extracardiac total anomalous pulmonary venous connection. Right? And I'm going to show you an example of that also in some of the imaging here in a moment. Seen in about 50% of asplenia, very rare in polysplenia. Okay, so if you have obstructed pulmonary veins, you're dealing more with an asplenia picture. Conversely, the phenomenon of what's referred to as ipsilateral pulmonary veins, where the pulmonary veins come into both sides of the atria, right on the right, left on the left, sort of at the polar opposites of the atria, a feature more of polysplenia, rare to see that in asplenia. Going down the list here, something that is quite interesting, bradycardia, and either sinus bradycardia or risk of heart block and arrhythmia. Rare to see that in asplenia. Asplenia patients typically have normal rhythms, but the polysplenia patients seem to have abnormalities of the rhythm. Now, you kind of think about this for a minute. Again, thinking about too much of a left-sided dose, too much of a right-sided dose. In the normal heart, the sinus node, which is the group of cells that dictates your rhythm, is a right-sided structure, right? So it kind of makes sense, there's a little bit of logic to this, that if you have a condition where you got too much left-sidedness, your sinus node, which is a right-sided structure, is not going to develop normally. And so you have some dysregulation of your rhythm. Your sinus node can be somewhat abnormal in polysplenia. Those are the patients who are at greater risk for bradycardia and heart block. And then et cetera, some of these other features here. Now, those are the features of the heart. Again, when these cilia beat in an abnormal manner, it's not just the heart that's forming abnormally, but it's the entire organs of the body as well. So in association, there can be a number of other abnormalities. So as I mentioned, immune dysfunction, very common in heterotaxy overall, whether it's asplenia or polysplenia. What's the implication of that? Our kids need to go on some daily antibiotic prophylaxis that we typically continue to about age 18 and then discontinue after that once you've developed sufficient immunity and kind of fall out of the high risk for bacterial infection with encapsulated organisms. That's pretty much what we're trying to protect you from when you're missing your spleen. Malrotation of the bowel is quite common. What's the problem with the malrotation of the bowel? Well, you can develop something called a volvulus, which is if the gut is not rotated normally and tacked down properly as food items go through your gut, your small intestine can twist, and if it twists on the pedicle of vascular supply, that can be an abdominal catastrophe with an ischemic insult, and so patients are at risk for that. Biliary atresia, and I'll just mention this, is something that is sort of the bane of our existence. For those of us that identify polysplenia and heterotaxy, mostly associated with polysplenia, and essentially impossible to identify prenatally. And so whenever we counsel a family, even if it's a simple form of polysplenia heart disease, where there may not be too much of a hemodynamic consequence, and we may not even need to do anything for the heart, the risk of associated biliary atresia, which can be a life-threatening condition and is a lifelong condition, requires surgical intervention and ultimately a liver transplant, is something that can be associated, and as I'll show you in the next slide, pretty highly associated with polysplenia. And there are a host of other things to look for. When we look at these extracardiac anomalies and divvy them up between the asplenia and polysplenia perspectives, intestinal malrotation equivalent in asplenia and polysplenia, but it's really the biliary atresia or absence of the gallbladder that's seen in about 20% of patients with polysplenia. And again, from the counseling perspective, it's a poignant situation when you're looking at a heart that has no significant hemodynamic difference, maybe something subtle with an interrupted inferior vena cava, and then that child's born and has biliary atresia, which is, again, a life-threatening condition. So you have to leave that open as a possibility in all of these individuals. All right, so that's some grounding, some foundation, which, again, hopefully you can use as a resource in the future. Let's look at some actual cases. So the very first, I think, experience some of you may have as imagers when you're scanning and your very first exposure to heterotaxy is seeing this. We're not even looking much at the heart here. It's kind of the thorax and the abdomen, and you see these two structures running in parallel. And no, it's not two aortas, which, in fact, I can tell you even currently, not an uncommon reason for referral is somebody in the community says, I think there are two aortas in the abdomen, what's going on? And that's fine because there are no such thing as two aortas in the thorax or the abdomen, but one of these is the aorta and the other is the azygous vein, right, which is a tiny, tiny vein. We all have one. Actually, we actually have two, some of us. And it carries very little blood flow. It connects up to the superior vena cava. But when the inferior vena cava is interrupted, the azygos then becomes that bypass conduit that carries your inferior vena cava flow back into the chest and it connects to the superior vena cava. And as you can see here in this case, we see our, quote, two aortas, not. One is the azygos, one is the aorta. And you can see the azygos making its way up over the top of the heart and connecting into the right superior vena cava as it drains into the top of the right atrium in a totally unobstructed manner. Blood cells don't give a darn that they have to take this detour, and that's really all it is. The detour itself results in little, if any, hemodynamic compromise. It doesn't need to be fixed. It's not a problem, but it's a flag that suggests that the IVC is interrupted, and therefore you're dealing with heterotaxy, most likely polysplenia type of heterotaxy syndrome. Okay, another case here. Fetus is vertex, and what I'm demonstrating here, in essence, is the presence of the clue of dextrocardia. And when you look posteriorly here, let's see if I get my arrow up. There we go. In cross-section, you're identifying the presence of these two circles. One is the aorta, one is the azygos. The azygos being, again, a retroperitoneal structure that runs parallel to the aorta. Another demonstration of these two circles, and I think I want to harp on this a bit more only because, again, I think it's going to be the most dramatic finding that you'll identify that will raise the flag that you're dealing with heterotaxy polysplenia syndrome. Turns out this particular patient has an AV canal defect as well, which is quite common in this situation. And because this is a polysplenia, you can identify if there's some evidence of bradycardia as well. This is sinus bradycardia at rates of about 100 to 114 beats per minute. Just a quick note on the serial follow-up of the bradycardia here itself. Since it's sinus bradycardia, it will be slower than normal, but it's rare for these types of bradycardias to drop to a point where we're below, say, 80 or 90 beats per minute. Unlike, say, in situations of heart block, where your ventricular rates will drop to as low as 40 beats per minute and develop high drops, it's unusual to see these bradycardia periods of sinus bradycardia of heart rates of 80 or 90 cause any significant hemodynamic compromise. All right, so having said that, here's another case. Vertex, again, I've identified the right and left positions here, and as you begin this sweep here, I'll point out to you that right here, I mean, the obvious thing is that we have high drops, but that's the stomach, and it's sitting on the right. Okay, so often in your initial sweep of situs, first sense that something may be wrong is the fact that the heart and the stomach are not on the same side. The apex of the heart's not pointing to the same side. So this apex of the heart is pointing to the left here, but the stomach sits on the right. We also happen to have somewhat of a midline liver and a situation of high drops. And looking into the posterior aspect, we do see these dueling structures with flow in opposite directions. And one is the aorta, one is the interrupted inferior vena cava, azygos continuation in a short axis. Coronal cut, you can see the two circles retroperitoneally. There is some element of bradycardia here, and we're seeing high drops, so that's beginning to raise a suspicion here that perhaps we may have a rhythm that's impacting the hemodynamics. And in fact, by placing an M mode, we do see disconnection between a steady rate of atrial beats and a ventricular beats at a rate of 49 beats per minute, so we have complete heart block in this circumstance. So interrupted IVC, azygos continuation, AV canal defect, complete heart block, a picture of polysplenia. One additional thing that was unfortunate in this patient, I mean, we have heart rates here in the high 40s, so that's pretty slow heart rates. And as if we needed another marker of distress of this particular fetus, what we see here is what looks to be evidence of coronary flow, which is contributed to by the bradycardia, which gives you an opportunity to identify coronary flow, but also likely a consequence of a oxygen supply-demand mismatch due to the hemodynamic consequences of what we're seeing here. And unfortunately, all of this is a marker of unwellness and most likely soon-to-be demise. Okay, another case. Starting out with fetus being vertex and on its back. So the arrow is pointing to the right, and we see the stomach bubble on the right side. As I put that into motion, you see that the heart apex is pointing to the left side. Now, I don't see the two circles that I showed you earlier in the retroperitoneal area. So perhaps this may be not a polysplenia, but perhaps an asplenia case. And as you begin to look at the heart, you can also determine that there is an atrioventricular canal defect. There's a single common AV valve. We're going to look a little bit more at that here in the subsequent images. And in fact, it appears to be somewhat unbalanced. And as we sweep more cephalad and look at the great vessels arising, again, this is the right side. Let's look at focus on this image here. This is the right. That's the left. We saw the stomach on the right. We see two great vessels arising from what looks to be mostly this right-sided ventricle here. And one bifurcates, the other does not. So this is the aorta. That's way to the right. Pulmonary artery next to it, slightly to the left. Both seem to be arising from this right ventricle and this unbalanced AV canal. In fact, what I'm just defining for you here is perhaps one of the most common configurations of asplenia, which is a double outlet right ventricle AV canal defect unbalanced with some degree of pulmonary stenosis. That's sort of a classic configuration that we see typically in asplenia. Probably one of the most common configurations of asplenia. And identifying the nature of not just the origin of the great vessels, but whether there might be any narrowing, often pulmonary stenosis is the case, and I think you can see some element of pulmonary stenosis here as well. The pulmonary valve looks to be somewhat thickened. And in fact, as we look at the arch views, we can see that there is some retrograde flow in the ductus arteriosus pouring into the pulmonary artery. So although the pulmonary valve may not look terribly atretic or terribly stenotic, it in fact is moving but nearly atretic, and there is retrograde flow in the ductus arteriosus, indicating this is going to be a ductal-dependent condition that will require prostaglandin infusion at birth to maintain pulmonary blood flow. So again, a pretty classic configuration of asplenia. We searched a little bit more here, and it turns out that there are bilateral SVCs as well. Often that's something that you can identify at the very outset in your coronal sweep, looking in this panel here, in your, quote, 3-vessel tracheal view, or in this case, perhaps more 4-vessel tracheal view. You see the two SVCs in cross-section there. And as we angle leftward in this long axis, you can see the left SVC coming down directly into the atrium. And finally, finishing up with this last case, Michelle has shown this beautifully. We've seen it a couple of times. I'm going to say that this group is never going to miss anomalous pulmonary venous return ever again, because you've seen some fantastic demonstrations of that. And here is a case of an AV canal defect. But as you look behind the atrium, you see this linear structure, which is the confluence of the pulmonary veins in this situation of heterotaxy. And here, we put the color on, you can see the veins coming together to this confluence behind the atrium. And as we flip to more of a long axis view, you see the liver, and you can identify the course of the veins heading infradiaphragmatic towards the liver. That's the confluence heading caudad, south, towards the fetal liver and fetal feet. And then here you can actually see it connecting in what looks to be the junction of the ductus venosus to the hepatic veins. By definition, infradiaphragmatic total anomalous pulmonary venous connection is going to be obstructed. Rarely they're not, but you can make the presumption that it's going to be obstructed. So basic outcomes for this condition, isolated vena cava are typically the case. Biventricular lesions confer a better outcome than single ventricle lesions. Those with complete heart block have near 100% fatality. And once you have single ventricle and high degrees of heart block, very poor outcome for that as well. Total anomalous pulmonary venous connection and pulmonary atresia have very poor outcomes as well. And when we look at overall outcomes for heterotaxy syndrome, it's about a 5-year survival of 50 to 65%. This is the insignia of colleagues up at Boston Children's who have put together a very nice multidisciplinary clinic to focus not just on the cardiac aspects, but all extracardiac aspects of heterotaxy syndrome as well. And I'm just going to finish by showing you this curve here, which is from our own series of unpublished data, showing that there's relatively early mortality, but once you get out to about 2 to 3 years, it's pretty consistent with other forms of single ventricle. But overall, outcomes are about 60% for patients with a heterotaxy syndrome. So it's a challenging condition to characterize in utero, but a systematic approach provides a mechanism for accurate diagnosis. Specific findings do dictate polysplenia versus asplenia, and the heart rhythm and the site of pulmonary venous return are the two factors that most greatly influence outcomes in this condition. Thanks very much.